So we'll be starting today's talk with a patient encounter that we had. It started like any regular day in clinic. A patient named John came in for a routine annual physical exam. He did routine blood work, and it came back that he had elevated blood sugar levels, indicative of prediabetes. As we were trained, we talked to him about steps he could take to prevent the progression of prediabetes to type 2 diabetes. We explained to him that he should be increasing his exercise, limiting his carbohydrate intake, and trying to follow a Mediterranean diet. Before I could continue, he stopped me, and he looked up at me and he said, "Mediterranean diet? How can I control my health with a diet that's not even mine?"
More than 37 million American adults have diabetes, and another 96 million have prediabetes. These diseases have become true public health and economic crises. Type 2 diabetes is one of the leading causes of death in the United States, often leading to fatal complications such as stroke, heart attack, and kidney disease. Not only do these diseases affect the lives of millions, but they also account for 25% of all medical expenditures in the United States, accounting for a whopping 2% of our GDP. However, type 2 diabetes is preventable and prediabetes is reversible. One of the main ways to prevent disease progression is primarily through lifestyle changes. The most important lifestyle change is a healthy diet. However, for many Americans, the road to health changes is littered by barriers and disparities. Access to healthy food and the social support required to implement this change are impacted by social determinants of health. Often, underserved populations are the ones who bear the brunt of these diseases the most.
So while lifestyle interventions are effective at reversing prediabetes, the growing prevalence of type 2 diabetes in our country signals that these efforts fall short. And so Peach Health aims to fill that gap through a prediabetes management platform that is patient-centric, and culturally competent, and specifically centered around nutrition. So food is more than just an important part of our overall health. What we eat and who we share our meals with defines who we are. And so current physician recommendations on the side of diet and medical nutrition therapies, they lack cultural competency. So therefore, they're often impersonal and impractical. So because food is critical in cultivating the diversity of our communities, there really is no one-size-fits-all diet to approaching and achieving glycemic control. So the 4 pillars of Peach Health are designed to improve the management of prediabetes through an intervention that will be culturally competent and patient-centered. All right, so at the core of our intervention, the cornerstone of our interventions are our registered dietitians. So our dietitians are not only certified diabetes educators, but they've also had the unique training of a federally funded, culturally and linguistically appropriate service. So it's a CALS education program. CALS education program, mouthful there. And the importance of this program is that our patients will be seen by someone who sees them. So the unique component of Peach Health is that our patients have the opportunity to choose the dietitian that they're going to work with on this journey to self-management.
Acknowledging that a lack of access to healthy food is often one of the largest drivers in disease progression, Peach Health offers members $40 a month towards high nutrition rated groceries. And leveraging existing resources, Peach Health partners with food delivery platforms such as Instacart to offer free grocery delivery, empowering members to regain control of their health through nutrition.
So navigating change is easiest when we feel supported. Peach Health offers its members access to a social network platform, Peachy Keen, where they can connect with other patients going through the program and also connect with past participants who have successfully managed their prediabetes through the intervention. In addition, they also have access to an extensive library of pre-recorded videos teaching them new cooking techniques and recipes so that they're able to sustain the gains they've made through this program. However, lifestyle changes aren't just about following a healthy diet. Countless behavioral, mental health, and socioeconomic barriers really influence the efficacy and success of any intervention. That's why our social workers develop meaningful and personalized relationships with our patients to identify individual barriers that they might encounter as they go through this program and help facilitate ways to drive empowerment.
All right, so what does the experience with Peach Health look like for a patient like John? So as an Optum Care patient, John's care team refers him to Peach Health after receiving a hemoglobin A1C level that is indicative of prediabetes. John will then have the opportunity to select the care team, the dietitians, the social worker that will work with him on this journey to self-management. And he'll meet with them to devise an individualized and personal approach and set of goals. An approach that can change over time as his disease and his life changes. Biweekly meetings with dietitians will allow John to embrace the role that food plays in managing his condition. And when he's not meeting with his dietitian, on off weeks, he'll be meeting with a social worker to identify and overcome barriers to lifestyle change, both tangible and intangible. Now, after a 6-month period, John will have his hemoglobin A1C reevaluated. He'll then transition to monthly meetings, taking a little bit more independence in the management of his care. And throughout this entire process, John will be supported by a community of individuals along a similar journey. And he'll benefit from resources like grocery stipends and grocery delivery, improving access to nutritious foods. And upon successful completion of this program, John will have the opportunity to graduate on to be a health hero and provide mentorship to other individuals following this journey to better health. So not only will Peach Health improve patient outcomes, but it will also generate substantial cost savings. Existing research revealed that for a patient with prediabetes who goes on to develop type 2 diabetes, they face medical expenditures north of $3,000 per year compared to a pre-diabetic who does not go on to develop prediabetes. So taking Optum Care's patient population into consideration, we project Peach Health will have the ability to generate up to $355 million in cost savings over a 3-year period by preventing disease progression.
So we envision 3 main modalities through which Optum can deploy Peach Health. Like we mentioned with John, one way could be through billing it as a billable service through Optum Care centers. However, we think the most scalable approach would be by partnering with health plans, taking advantage of the patient population that Optum is able to cover. Not just those who are covered by United, but other plans as well. Thus, we envision Peach Health being stood up as either a fee-for-service model or value-based care model. And lastly, in the future, we hope to partner with employers to be able to improve the health of their employees, as well as to prevent unintended medical costs.
And then to stand up this plan, we envision a 4-phase approach, with the first 2 phases focusing on efficacy and feasibility. And then depending on the research there, the following 2 phases on improvement and expansion, with the ultimate goal of gaining recognition as a DPP certification.
So the bottom line is that prediabetes poses a massive threat to the American population. It's clear that this condition disproportionately impacts individuals in underserved communities. Through Peach Health, Optum Care has the opportunity to help millions of patients, just like John, manage his prediabetes through culturally informed lifestyle modifications centered on nutrition. the theme of this case competition being, health inequities. I know something that's come up a lot, especially as healthcare services become ever virtual, telemedicine oriented. There's a big concern about technology disparities, right? So some of these, this population that you're targeting, financially unstable, under-resourced folks, maybe they live in rural areas where there isn't high-speed internet and they don't have an unlimited data service plan. And yes, they have a smartphone, but also the time they have to spend in, meetings with dietitians and social workers and all these things might be limited. So can you guys talk a little bit about any of the research and discovery you might have done within that population to figure out what they have access to today, on the sort of digital side, and also in the sort of time and engagement through digital apps? Any research you guys have done?
It's a great question. And I think it's really important to acknowledge that oftentimes in trying to break down barriers, we might just be setting up some others. And so the study population in previous work on diabetes I took was actually in Atlanta. So we had a similar idea of standing up a digital intervention, and did research through Grady Hospital. So it's a large publicly funded hospital with primarily underserved individuals benefiting from the care. And what we found is that, like you alluded to, most people do have a smartphone, but a lot of times what the major barrier is downloading an app. And so one thing we've considered is instead of having to download an app, what's actually more effective is if you can send a text to open up a link and have it a completely online platform. So that's just an example of some of the research that went into thought here to limit those barriers there, yeah.
So you have sort of two models going on here. You have the nutritionist / CDE, and then you have a social worker. So what is the value of both of those when you were modeling this out? How much more incremental value you actually get out of the social worker? Because there's going to be a lot of costs there. And to your point, you're doubling the amount of visits and creating just another, I always worry about engagement with apps for all of the reasons that you were just saying too. Why both right now? What's the financial add there?
It is a digital app in which if you need mental health services, you can find any therapist or licensed social worker and connect with them when they're available. So we want to follow a similar model where our social workers and our dietitians would be on the platform like that. And the reason why we have both is because all research shows that while nutrition is important, what's even more important is the behavioral and the mental health perspective. So we can set out to do as much as we want to do as people and set goals for ourselves, but if we don't have the support and really someone helping us along that journey as an advocate, most efforts fall flat. We need to have a personal coach to push them along.
And I'm just curious how the dietitians on your platform be different from other telehealth dietitians currently working the diabetes realm specifically.
Yeah. So the main goal there is that they are as effective as this current dietitian. So I'm sure you're familiar with DPP, so Diabetes Prevention Program. So you can have a qualification. We talked about CDE, Certified Diabetes Educator. The other certification that our dietitians will receive, I alluded to, it's the mouthful there. So it's actually offered by HHS, and it's a free program, but it's culturally and linguistically appropriate services. Sorry, it's a mouthful. Gets me every time. But so it's through this training. So it's a 5-hour training and also requires recertification where healthcare providers learn how to engage. So acknowledge their cultural roles and what they bring to the table and how to engage with others from others' backgrounds and use those as strengths. So that's a real key to our intervention there.
So many issues in patients receiving care is because their healthcare providers, whether that be through nutrition or through primary care, are not able to see them for who they are because they may not be able to relate to them or to understand the lived experiences that they've gone through.
And you also talked about free $40 and some
Instacart,
yeah, Instacart, right? So that's an awful lot, right? Can you just again go over the the actual addressable population that you're targeting? And then are they being referred to your app via their PCP, and then is that going a prescription? And how do you generate revenue and then also pay for these other, the sociologist or psychologist and dietitian?
Yeah, so we'll run through this quickly. So the model we presented was a patient seen in an Optum Care clinic. And so we broke it down in terms of addressable population based on the prevalence of prediabetes, multiplied in percent of patients who report that they see a physician at least once a year. This was last year's data collected by CDC. That's how we got down to our total addressable population. They see down there at the bottom, 1.3 million people.
Real quick, just to inform the assumptions we made for patients enrolling in Peach Health as well as the completion rate, those were taken as average, what the base numbers were from the CDC's diabetes prevention program. So all of our assumptions have been evidence-backed by existing research.
And the assumptions are that we are going to be no better than that program, which we hope we beat. And so moving on to costs, adding in all these costs. So again, everything was rooted, so our $40 a month was rooted in existing research. So there's outstanding clinical trial right now going on up in Boston. And they're looking at giving $30 a month towards patients to have the exact same impact or study the exact same impact. And so it was in our model to add a little bit extra. The other thing that we wanted to beat is recognizing the plans through those who are dual eligible for Medicare and Medicaid to receive $20 a month in grocery stipends. So just seeing that it's it's a solution that exists and works, and healthcare companies pay for it. Finally, mentioned two models there, right? So the first one, the one we presented, is through Optum Care. So the idea there would be referring patients who are being seen in Optum Care's facilities. And there's a couple of different models. One would be a billable model, just like a billable service already exists, so in the healthcare space. Currently, the limitations there are that the billing codes are really only accessible to those covered by Medicare Part B. What we really see as the most scalable and impactful way to stand this up is through a model that Optum already uses in a chronic disease management platform. The idea here is your main target is health plans. So you're charging health plans either through a fee for service, so per patient base, rather fee per patient, to manage these risks, or through value-based. So establishing this cost care before you collect revenue. And we really think that's the way to stand it up. Again, so it's Optum offering a service to other health plans.